I'm going to do something. I wanted, first of all, to thank the Centre for giving me an opportunity to speak. I love the fact that it's health, law, policy, and ethics, because the talk I'm going to be talking about, I'm going to be talking a little bit about health, a little bit about law, and a little bit about policy, and a little about ethics. Thank you. And so I'm going to be doing a little bit of that. But I am not a lawyer. People who know me will tell you that I am a reforming psychiatrist. And that doesn't mean I'm reforming psychiatry. It means I'm reforming myself as a psychiatrist. And I work in policy. I work and I run the Wellesley Institute, which is a research-based policy think tank. And we're interested, and very interested, not just in the social determinants of health, but we're really interested in equity and what equity means, and equity or substantive equality. So the lawyers call it substantive equality, other people call it equity, but it's the same thing, how we make things fair. And I wanted to talk today, or actually I wanted to try and get you guys interested in something that I believe is bound to happen, that we have to work out how to avoid. I wanted to talk about the fact that we have become immune to inequity. We've become immune to it. We allow it to happen. But when it comes to climate change, we've got to think of what we need to do to make sure the health impacts are not inequitable. So I'm not a lawyer, you guys are, and I understand we've got a brain trust here. I think other people have called it a brain trust, and I'm hoping that you are a brain trust. I'm also hoping to try and get somebody interested in picking up the ideas that I'm going to come to you with, and tell me what can be done, if anything can be done, if the law is our savior. Because I can see an avoidable tragedy occurring and wonder if the law or legislation can help prevent it. And I'm going to talk about 4 things. The first part of the section will be called Mind the Gap. And that's interesting because I think already today, I think it was, trying to remember, was it Lucy who you were talking about mind the gaps being a phrase that's been used in other places. I'm going to talk about inequities and disasters. I'm then going to talk about climate change and mental health and equity. And I thought that beforehand, Steve was going to be talking a lot about climate change. So I've taken just a really narrow slice in not just in looking at climate change, mental health and equity, and thinking what can be done to help with the problems that this is going to cause, and then could the law be our savior? So I'm going to start by trying to get you guys in the room. How many of you have been to London, England? Wow, well-traveled, well-traveled. How many of you have gone on a tube train and have them say, and listened to them say, mind the gap? Yep, you've all heard it. Okay, how many of you have any know why the gap exists? No one. So you've gone there and you've been told to mind the gap, and you've minded the gap, but you've never really wondered why the gap exists. It's quite simple. It's because some platforms are curved and trains are not curved. And because some platforms are curved and trains aren't curved, there is a gap at some point between the train and the platform. Okay? Very simple. Okay? That is why there is a gap. Now, the gap's actually been there since the start of the tube. So 160 plus years, there's been a gap between the train and the platform. About 300 people are injured in falling between the train and the platform every year. And very few fatalities, but there are fatalities. Yeah. And there are loads of solutions. You could, in theory, go around and make all of the platforms sort of straight. That would work. You could have much smaller carriages, and therefore they'd approximate better to the curve and the platform. That would work. You could have little bridges that come out from when the doors open, and they do that on some trains, and that would work. Or you could have a big inflatable thing that came between the train and the platform, so nobody could fall between the train and the platform. There are loads of things you could do to stop people falling between the train and the platform. But when the London Underground think about it, they say, 300 people? Yeah, that's expensive. Yeah, I'm not sure that is something that we're going to do. And so when they do their cost effectiveness analysis or risk analysis, they come up with the conclusion that it is just too expensive to do anything about it. And so they've come up with a low-cost solution, which is mind the gap, okay? And of course, that low-cost solution puts the responsibility back on the individual. So that's why there is, you hear mind the gap. It's a very simple, inexpensive, doesn't work very well solution. There's no evidence that it makes a big difference. So really, there's not just one gap. There's a physical gap, which is a very simple physical gap between the train and the platform. But there is also a philosophical gap between what we need, what the population might need, and how you think about risk, benefit, or cost effectiveness. And your actual gap and the reason why we continue to have the gap, and all of you who go to London hear the phrase, is because we haven't breached a gap. 50,000 people have realized this, because that's approximately the number of people who've been injured in falling between the train and the platform over the years. Yeah. And those 50,000 people are injured because we haven't been able to bridge the philosophical gap between what is actually needed and how we work out cost effectiveness. If we even just started working out cost effectiveness over 100 years, as opposed to 1 or 2 or 3 years at a time, we would change the balance of what we're doing here, okay? Now, why did I start by talking about this? Partly to get you in the room, partly because it's something that I knew that most of you will have been to London. I know most of you would have heard Mind the Gap. I knew almost none of you would have understood why the gap was there, because I was there for many years, and it was 10 years ago that I actually started thinking, why does that bloody gap exist? And started looking through. So I thought probably nobody would have done it. But it's actually to make you think about what happens when we don't bridge the philosophical gap. And it's really important to think about that because it happens in other places. So you're probably trying to work out, if we're talking about climate change, how we started with the London Underground and now we've moved to the Titanic, yeah? Well, the Titanic is, as you know, the ship was built and it was supposed to be unsinkable, and on its maiden voyage, it hit an iceberg in the middle of the night and the Titanic sank. What you probably also know is that's one of the worst maritime disasters, and why it was such a bad maritime disaster was the percentage of people who died. 1,500 out of the 2,224 people on the Titanic died in the icy waters in the middle of the night. So it was a significant maritime disaster. Now, if you went to the London School of Hygiene and Tropical Medicine and learned epidemiology, they will have taught you in your health equity class about the Titanic. And the reason that they've taught you is your risk of dying in the Titanic was completely linked to your gender and your age and your ticket. Actually, if you were a child or a woman in first class or second class, you actually had a 90% plus chance of survival. You're very likely to survive. If you're a child in third class, you had about a 30% chance of survival. If you're a man, you had a 30% chance of survival. Yeah. Why do you think that was? No? Where you were located? Somebody else said?
I was actually just in Belfast and learned about all of this.
Yeah.
Also where the lifeboats were situated. So lifeboats were situated closer to first class than they were the other class.
Yeah, so where the lifeboats were situated, where you were situated, so first class, upper desk outside, close to the lifeboats, third class, internal, lower berths, further away from the lifeboats. You hit an iceberg in the middle of the night, all chaos. Yeah. Then on top of that, those are also, somebody said culture. Yeah, women and children first. Okay, so two things happening: culture, women and children first. Second, class. Culture times class times disaster strategy that doesn't think things through, and you get one of the worst maritime disasters that there'd ever been. When you went there in Belfast, did they tell you that the lifeboats weren't full? Yeah. Yeah. Sorry, there weren't enough of them, but they weren't even full. They weren't full. People died, and there were lifeboats that weren't empty, but they weren't full. They hadn't thought through their disaster strategy to meet the needs of the people who most needed it. If there had been more help to people in third class, more of those kids would have survived. If there had been direct routes to the lifeboats from third class, it would not have been the biggest maritime disaster that had ever been. A whole bunch of it was survivable. But because their disaster strategy didn't take into account equity, the strategy didn't work as well, and people died needlessly. Yeah? Now, what are you sorry for? Sorry? Oh, to disturb me with the sound. There are many worse things that can happen. You'd think we'd have learned our lesson. Yeah? 2009, this is H1N1. The H1N1 influenza pandemic, and exactly the same problems. Yeah. We must have known, we knew that H1N1 was going to hit indigenous populations hard. We knew H1N1 was going to hit racialized populations hard. We knew H1N1 was going to hit people with low incomes hard. We had no pandemic strategy to deal with that and to meet people's needs. And because of that, we ended up, whether it's adult infection, child infection, hospitalization, deaths, multiple increase in rates for racialized populations, indigenous populations for H1N1. This is predictable, just like the disaster in the Titanic was predictable. And you'd think we'd learn our lesson. We are slow learners. Yeah. Let's go forward to COVID. 100 years of knowledge on disasters and inequities. Recent data from H1N1 on disparities in infections and deaths for racialized, indigenous and low-income populations. And still, when we went into NH1, into COVID, we had no equity focus for our strategy, and we didn't even have the data systems to be able to measure who was getting the service and who was not. It's not all bad news. All this is showing is the deaths per 100,000 population in selected countries. And you'll see, if you start off with Brazil, Mexico, USA, Italy, UK, that is Spain, France, Sweden, Switzerland, Germany, and then you get to Canada, yeah, and Ontario. We actually had quite a good pandemic response. Our deaths were quite low. They weren't as low as Finland, Norway, Japan, Australia, and New Zealand. We didn't get to those levels of efficiency in our pandemic response, but we had a pretty good pandemic response. And there are good things and bad things about that. The good thing is it shows pandemic responses can significantly decrease the rates of infection and deaths. So pandemic responses work, and Canada's pandemic response worked, and Ontario's pandemic response worked. The disappointing thing is that it only worked for some people. We sacrificed our older people. Didn't need to happen. Other countries didn't. We sacrificed our older people to this pandemic. We sacrificed people with pre-existing health conditions, racialized groups, migrants and refugees, homeless populations, and people in institutional settings. We didn't need to have to do that. Those were decisions that were made, and those decisions had significant impacts. This is difficult to view, but I'll make it straightforward. All this is 4 graphs: cases, hospitalizations, ICU admissions, and fatalities for different racialized groups. And at the bottom of each group is the white population, which has the lowest rate of cases, hospitalizations, ICU admissions, and fatalities compared to every other racialized group, with the Latino population being the population with the highest rates of everything. And these rates are sometimes 10, 15, 20 times the white population. Yeah. So this is looking very much like the Titanic, where you have groups who have multiple sort of increased risk of death, and other groups who are going to survive. And it doesn't have to be that way. Just showing why it doesn't have to be that way. So one of the things they did during COVID was worked with a group called the Black Health Equity Working Group. And this was a loose coalition of people from community, people who are service users, service providers, and policymakers, all of whom wanted to try and develop a pandemic strategy which met the needs of everyday people and racialized groups. And the first thing we were trying to do is get the province to change the law so that data was collected, and we had data, race-based data. And then we wanted to use that to be analyzed and set up a evidence-based, equity-driven pandemic strategy. And this is the Black Health Equity Working Group. And actually following this work, the Black Health Equity Working Group managed to get the government, and Ontario is one of the few governments in the country to have a Black Health Plan, and who funds the Black Health Plan in order to try and push forward Black health equity. So it was a successful group. The province changed the law. Data started being collected, and different public health units tried to do different things. So Toronto not only started collecting data, they took the data, took it to community, and said, what would a pandemic strategy that was equitable, what would that look like? And they produced a culturally adapted public health response. And then on top of that, because the community were asking for it, there were action on the social determinants of health. And there you see Joe Cressy, who was the councillor, and then you see Eileen De Villa, who was the medical officer for health, who got known, you know how Bonnie Crombie got known for, not Bonnie Crombie, Bonnie Henry, got known for her shoes. Eileen De Villa got known for her scarves. And as you know, there's nothing sexist about the fact that the men are known for the policy and the women are known for their clothes. Nothing sexist going on there at all, is there? But we won't go further with that. But this is what happens when you set up equity-driven, evidence-based public health strategies in COVID. What you're seeing here is the rate of COVID infections for 4 different racialized groups compared to the white population. And you're seeing what happened between June 2020 and December 2020. So if you, sorry? Yeah. So, and the things you can do, yeah, right? You can do sort of things you can do that once they set up these equity-based strategies, you can put more buses on the routes that racialized populations use to get to, for essential workers take to get to work. You can give free hand sanitizer. You can give free masks. You can try and work out places that people can isolate and give free places for people to go and isolate so you don't infect the whole family. There are loads of things that the population came up with. You could translate the advice, you know, simple things like that. Came up with loads of ideas, and between June and August, these are the things that were implemented. So if you're the Latin American population, origin population, in June 2020, your rate of COVID was 11 times that of the white population in Toronto. By the time you get to December, it's about 5. If you're the black population, it peaked in August at 9 times the rate of the white population. By December, it's twice the rate. Whichever group you're in, yeah, you can see that over time, the rates are coming down when you have an equity-based pandemic strategy. It's totally possible to look at your strategy, whether it's a disaster strategy or a pandemic strategy, whether it's H1N1, influenza, COVID, or it's the Titanic, and think, how do we engineer our strategy to really meet the needs of people who are most at risk? Yeah. And if you do that, you can make a big difference. Okay, so it's possible. Overall, if we wanted to go from where Canada was to where Norway was, or Finland, or Australia, or New Zealand, if we're focused on equity, that's a way of getting there. Okay, so that's a positive way of looking at it. But we started off by talking about gaps and mind the gap. And the gap that I want you just to think about is the fact that we know this. We knew this all along. Yeah. But there doesn't seem to be anything that makes governments that makes public health take equity into consideration when thinking through these disasters or pandemics. There's no law there seems to be no law that means that they have to, from the start, make sure that they set a plan that's going to work for the most vulnerable. It seems to be something that's missing, and that's the thing that I want you guys to think about. How could you do this? How could we make this happen? How could we move to a position where this is hardwired, or this is something that just has to happen, that we expect to happen? Because climate change is going to be, not once it gets going, as it accelerates, is going to be like COVID on steroids. Okay? And if you think the disparities during COVID were something, start looking at what's going to happen in climate change. We know what happens, who gets affected by heat, flood, fire, weather, weather volatility. We're not thinking as much at the moment as we should be about infrastructural damage. What happens when there are key resource problems is that the people who have more power might, and they take stuff, and they take stuff away from other people. Scarcity of water, that is going to be an issue, maybe not as much for Canada, but certainly in parts of Canada at certain times. And if you've been looking at the rising rate of food insecurity, and we haven't even got into climate-driven food insecurity, you can imagine what's going to happen as we go forward. We are going to get infectious diseases, new infectious diseases. We've already, with austerity and food insecurity, seen scurvy in Ontario. Scurvy, due to lack of vitamin C. We're seeing rickets in Ontario, lack of vitamin D. We're seeing Victorian-era diseases coming back because of food insecurity, and it is going to get worse. And we've seen displacement, and we've been talking about the mental health issues, because these mental health issues are going to be severe. We've got physical stressors, psychological stressors, social stressors, societal stressors, who are going to be interacting with existing risk factors to increase the rates of mental health problems, but also to increase the impact of existing mental health issues on people with mental health issues. People's lives are going to be made worse. We know that climate change is not going to be felt equally. We know that people with mental health problems are going to be at increased risk. We know that people with existing social determinants will be at greater risk. And we know that this is going to have a big impact on children and youth, older adults, Indigenous peoples, racialized communities, people living in poverty or homelessness, sorry about that typo, and those with disabilities. That is what is going to happen. This should not be news. We know this is going to happen. But you remember I started off by saying, have we become immune? We know that this is going to happen. We know that this is going to be a tragedy. And the question I'm passing back to you guys, what are we going to do about it? What can we do about it? Are there instruments in the law that we could use to make this better? You know I'm a researcher, and so I do stats. And so I cannot help but give you some stats. There are going to be 250,000 deaths, extra deaths, due to climate change between 2030 and 2050 worldwide. We will be at this situation where 99% of the world will be breathing unhealthy air by 2044, by 2044. We will have 150 more people moderately or severely food insecure, not just food insecure, moderately or severely food insecure globally. But locally, here, we're going to see an increases in food insecurity. We're going to see deaths because of heat, cold, and flood. How many of you will have smelt the wildfire smoke? You can put your hands up. How many of you? Everyone. Yeah. How many of you know the impact it's having on your health? No one. How many of you know the strategy for dealing with the increasing cancers, asthma, and heart problems that are going to come from wildfire smoke? No one. And that's reasonable because we have no strategy. Okay? There is no strategy. Yeah. The strategy, and now there are new risks. We have West Nile virus in Toronto. So we have a mosquito-borne encephalitis-producing virus, which is now in Toronto because the virus has made its way up from the States, and there are going to be other illnesses coming our way. And Steve was talking about eco-anxiety, which is a very real thing in Toronto. There are people like the WHO who've been thinking about what we should do. Integrate climate change into our mental health policies, integrate mental health into our climate change policy, build on the existing commitments that we have nationally, reduce vulnerabilities to climate change by multi-sector approaches, and assess and address the funding gaps in mental health and impacts of climate change. And that's generally the model of what we should be doing. But we generally have slightly different approaches, which is mind the gap. Fire, our response, evacuate. Flood, our response, evacuate. Heat, don't go outside. West Nile, avoid mosquitoes. Food insecurity, go to food banks. Climate anxiety, yeah, don't be anxious, okay? Our responses are about passing all of the response to climate change to yourselves. How does it work? Don't go outside. I'm houseless, I live outside. Don't go outside. I have a terrible apartment because I have mental health problems and ODSP gives me so little money that I'd like to spend time outside rather than in my apartment. How's that going to work? Avoid mosquitoes. How does that work? I live outside. Stay inside and cool off. Yeah, but there's no law that means that there has to be aircon in my apartment. Yeah. And so we could go on and go on and go on. Yeah. These tend to be our responses, but we know we need something more fundamental. But that's not really what I'm talking about. I'm talking about fundamentally not only thinking about systemic responses, but making sure those systemic responses meet the needs of the people who are made most marginal. And what could we do in order, whatever responses, to make sure they work? Okay, so by now, I have increased the number of people who are going to go and get consults at the Royal because I have depressed you all to a point. It is a way that I tend to try to make sure that I ensure my OHIP billing is kept up, is I come and I give talks about disaster and terrible talks and then afterwards I leave you my card saying that I'm a psychiatrist and if you need help, I am here for you at any time. at the normal OHIP billing rate. It is something that I've been doing for years, and it keeps me in good suits. But it is not something that I would ever think is reasonable. And so obviously, the work is to try and work out how to stop you guys coming to me rather than to make you come. And one of the things, and probably one of my first forays into climate change work, was back maybe over 20 years ago. And this is just to give you a sort of go from the statistics, go from into just an actual case study in what happens in a middle class area in a high income part of the UK, a high income country in a middle class area with great infrastructure and national health service, and who has what in many ways would be considered a relatively sort of a small located flood because a river Ouse broke its banks and flooded a number of homes. And we're able to do a case control study where we had some parts that were flooded, some parts that weren't flooded, and we were looking to see what happened over a period of time. And this study was done 9 months to a year after people had been flooded. Okay, so we know that it's, you know, when you're flooded, I mean, there are accidents and various other things that happened. And we wanted to say, we're saying, okay, well, we'll take all that into account. What actually happens in the medium term afterwards? What happens later? One of the things that we were surprised at was that 9 months after you'd been flooded, you had a 50% chance of being clinically depressed. Yeah. So this isn't straight after you've been flooded. This is 9 months after you've been flooded. 50%. So background rate would maybe be something like 12 to 13%, maybe on a bad day, 15%. So 3 to 4 times the rate of depression, clinical depression, from being flooded. If you had physical health problems like gastroenteritis, earache, or anything like that, that sometimes happens with flooding. Actually, it was the people with mental health problems who were the people who had the physical problems. Having a mental health problem predicted your chance of having a physical health problem. Having a physical health problem did not predict your chance of having a mental health problem. So mental health problems were driving these problems. And the risk of physical problems was greater in those with depression. And we said, well, why is this? And obviously we thought it must be the trauma of the flooding that was an issue. And it was an issue. We thought it might be insufficient mental health supports. Probably not so much of an issue, but it was an issue. But the big issue was the economic impacts of flooding and the lack of social or economic protection for those who were flooded. And give you an idea of what I mean. You have a 3-story house and your ground floor is flooded and you've taken out insurance and your insurance is for $100,000. Yeah? And you assess what's happened and the assessment comes to $99,000 for all of the stuff that's been ruined on your ground floor. You go and you make your claim in the UK. This is what's happening in the UK. And if you go to an insurance firm in the UK, the insurance firm says, yeah, looks like you got $99,000 worth of trouble there. But we covered the whole house, which is 3 floors, and you've only got 1 floor that's got a problem here. So you must be underinsured. We'll give you 33,000 as your settlement because, you know, we've got 33,000 for the next floor and 33,000 for the next floor, and that's what the coverage should have been. So you're just undercovered, and so we're not paying. Yeah. And there are loads of scams like that that people got caught up with. In the UK, you move for your job. These guys couldn't move. Yeah. So they were stuck. Your biggest financial stake is your house. It wasn't worth anything. It's on a floodplain. And so it goes on. There were no protections. So what I was trying to do is just give you some ideas of some of the issues which are not due to the trauma, but are due to the lack of other protections that will lead to mental health problems, many of which we wouldn't consider until we've been in that situation. So that was just to give you an idea. I think it's reasonable to say that those who've been made most marginal will die in disproportionate numbers and be more at risk of illness unless we have an equity-focused mental health and climate change strategy. Agree? Yep, some of you agree, some of you don't agree. If you don't agree, I haven't done my job properly. You have to explain why you don't agree, right? I think it's pretty clear, whether it's Mind the Gap, whether it's the H1N1, whether it's COVID, whether it is Lewis, whether it is the Titanic, I think it's reasonable to assume that this is the case. And the question I have, oh, did you need that? I can go back. Good? So the question I have for you, and this is what I'd like you to discuss and tell me, because I am not a lawyer, is could the law or legislation be our savior? We know that the impacts of climate change will be profound. We know that governments will not prioritize people made most marginal unless we make them. We know that that's going to happen. We know climate change is going to be a problem, and we know that something needs to be done to protect the people most marginal. Otherwise, they're disproportionately going to have the effects, the mental health effects, the physical effects of climate change. And that is what is going to happen. Is there something that can be done? And I was interested earlier to hear various ways in which a law could be enacted. And is there something the law should do? We talked about charter, we talked a little about human rights earlier. There's a question about legislation and things like the Race Relations Amendment Act. Have you heard of that act? This was an act in the UK trying to promote, which was after a, which has been found by the Audit Commission as the most important single factor for increasing equity in the National Health Service. And it was an act which lasted from 2005-ish through to about 2015. And it gave all public services 3 big duties. And the 3 big duties was that they had to promote positive race relations, they had to have services that were equitable, and they had to have the data to prove that the services were equitable. And the Audit Commission, which is a right-wing group, said, it worked. And the Conservative government that came in said, we'll get rid of that then. And that's what they did, but it worked. But it's a way of thinking through types of legislation and sort of things that you might ask public services to do that work to promote equity. New regulation, we were talking about transfers, and is this something that the feds would like to tie their health transfers to having sort of equity strategies? And then there's the conversations we had about individuals or communities taking their governments to court and how that's gone so far for eco-anxiety, but also could go for other things. So that's the question I have for you, is what are we going to do? Yeah, I feel like you can see the train coming down the tunnel, and the question for me is there any way of stopping it? Because if we haven't got a way of stopping it, and if there is no way of stopping it, we know what the outcome is going to be. Yeah. And one of the things I loved about listening to some of the talks earlier, especially Lucy's talk, is that paradigm shifts can happen. It is possible for things not to have been there beforehand and people just to say, I've had enough of this. Yeah, this is not right. We have to do something different. And the fire in my belly at the moment is, this is going to happen unless we do something different. And it keeps on happening, and I've had enough of it. So guys, the question is there something that can be done? Is there a remedy? Is there a new law that there needs to be? Is there a way of heading this off so that we don't get into the position where in 10 years' time when things are accelerated and we see the deaths and we see the increased rates of cancer and we see mental health, we see the rates of relapse going up, when we see the disasters that will be happening for our houseless populations or itinerant populations, and we see the increased rates of problems in Indigenous, racialized and low-income groups, we can't sit around and say that we didn't see it coming and we didn't try anything. Because if we don't do anything, I do think that this is just a disaster that's already happening. So thank you.
We're going to take a 5-minute break. Stretch your legs.
Ooh,
Grab some water. We'll
no questions.
32, 31.
No questions?
Everybody seems very quiet. Are there any questions?
Well, I'll try one.
Okay, Jen's going to try a question.
One, do you have any ideas I'd ask? I know, but also you pointed to some jurisdictions that did relatively well in COVID. Can we learn from those who have not had these kinds of trends? What exactly was it about? What exactly was it about those societies, demographically, policy-wise? Who are the people who are avoiding these problems, and how are they doing it?
So say, for instance, if you look at COVID and look specifically, say, for instance, at the older populations, so older populations are at incredible risk, and you look at Germany. Germany, right at the start of the pandemic, asked a research-based independent body to look at what the best way to go forward was. And the Koch Institute produced guidance that wasn't guidance on what should be done in long-term care homes and for older populations. The percentage of people who died from COVID in Germany that were older, I think for us it was about 70%, for them it was about 30%. So actually having independent organizations helping creating the guidance made a significant difference because they made fewer assumptions and also actually had equity driven through the way they thought about things. So it is completely possible to get advice. But, you know, my question is, how can it be legal to knowingly set up, whether it's a pandemic, oh, I'm coming close to that, that's a problem. How can it be legal for everyone to pay their taxes and then we set up a pandemic strategy that we know isn't going to work for some people? Yeah, and how can it be legal that we're going to set up a climate change strategy that we know is not going to work for people with mental health issues and isn't going to work for certain parts of society? And that's the question I have, that how can it be legal and how can we sit and say that's okay?
I think you're onto something that's just speaking personally with the focus on data, because deniability is a big part of the inertia. I think setting up a regime that insists on the collection of data ex post is always going to be ex post. But to set up a regime that requires the forecasting, the prediction, the modeling ex ante might be more powerful, because once the model's out there, it's public, it's sort of an anticipatory data, it becomes hard to sit and do nothing, as opposed to the speculative. And I wonder, like, this is not my area, so please forgive me, guys, but I'm thinking we have so many of these different kinds of impact assessments, an environmental impact assessment. We used to do technology, impact of technology assessment, an equity impact assessment of some type to do this anticipatory requirement for policy decisions.
Yeah, so two things. First thing, I totally agree with you with data. The experience of the Black Health Equity Working Group was that we were pushing for data collection, but use and publication. And so it wasn't just collecting data, there's loads of data. The question is whether it's used, and whether it's published, and whether it's transparent. And one of the reasons why Toronto did so, moved the way they moved, is because we managed to get them to start publishing the data. And so the data was published and available, and the disparities were available and were broadcast by the media, and they had to do something. So it's the use of data, and the use of data was so useful that when it came to the vaccination, the government of Ontario decided that it didn't need to be collected.
Yeah.
Right? Because it was useful, very useful. So I think that the data is important, but not just the data, the use of data and the publication of data, and preferably, because I'm greedy, the community governance of the data as well, so that there is sort of the data justice element involved. So I think I totally agree, but we have models that show that it's possible to make big differences if you do this sort of thing. And with regards to health equity impact assessment, the province of Ontario produced a health equity impact assessment tool based on an international research that was built in collaboration with Wellesley Institute before I was there. And until this year, it was hosted in the Ministry of Health's website, and it was supported by the Ministry of Health. And they also supported a health equity impact assessment community of practice, which had hundreds of people involved. They've just shut it all down. So the stuff exists. Health equity impact assessment is there. The Ontario version is there. There's even a public health version that's there, but it's been shut down by the ministry. The positive is wait till you see the new public health guidelines that are going to be published soon. Because I think there's going to be some things in there that can be levered towards the goal of ensuring that public health starts producing plans that are truly equitable.
So Kwame, thank you very much for an inspiring, somewhat depressing, but also you've ended on an uplifting note. We can look forward to the public health instruments that you're talking about, or guidelines. So thank you very, very much for being here with us. We appreciate it deeply. Thank you. Sorry?
Business cards.